Welcome to our workshop at AMP. Comprehensive genomic profiling is rapidly becoming the standard of care in oncology. In this workshop, our panelists will describe the benefits of implementation of a comprehensive genomic profiling assay at their institution with a focus on three key parameters. Number one, reasons to internalize and the value of a flexible DNA+RNA comprehensive genomic profiling assay. Number two, the impact of reflex comprehensive genomic profiling on testing decision trees and workflow consolidation. And finally, number three, the value of sample management and genomic literacy for oncologists and molecular tumor boards. And now I'd like to introduce our three panelists. We have Nikoletta Sidiropoulos, the Associate Professor and Director of Molecular Pathology at the University of Vermont, Larner College of Medicine. Our second panelist is Jeffrey Conroy, Chief Scientific Officer at OmniSeq and Director of Genomics Technology at Roswell Park Comprehensive Cancer Center. And our third panelist is Jeremy Wallentine, the Medical Director of Molecular Testing at Intermountain Healthcare.
Hello, everyone. Today, I've been asked to speak about comprehensive genomic profiling and to specifically share my experience regarding local implementation of genomic analysis. We come together today with slightly or vastly different experiences and perspectives as it relates to the practice of genomics. So, I will begin with a quick overview of my practice environment to hopefully facilitate your ability to appropriately generalize the content of my presentation to your experience or practice in the clinical genomics sector. Before I officially begin, however, I would like to thank Illumina for the invitation to speak and share this disclosure with you. Please be aware the opinions I share with you today in this presentation are my own, and I may not represent the opinions of Illumina. In 2013, the University of Vermont Health Network committed to making genomic medicine a centerpiece for prevention and treatment. The UVM Medical Center officially opened the Genomic Medicine Laboratory on January 27, 2017, to expand the use of advanced genomic testing to empower physicians to develop and administer treatments tailored to individual patients. We practice within the Vermont All-Payer Accountable Care Organization model, which is a healthcare payment model in which payers incentivize healthcare value and quality with a focus on healthcare outcomes. The overall aim being to transform the healthcare for the entire state and its population. There was a local recognition early on in this model that genomics plays a considerable role in the health and well-being of our population, and so the health network leadership, in alignment with pathology and laboratory medicine, amongst other healthcare service lines, made a commitment to develop and support the genomic medicine program. Our health network serves over 1 million people in Vermont and northern New York, with a full range of tertiary level inpatient and outpatient services. We all recognize in this space that increasingly more information is requested from limited tissue. At the time of starting and visualizing this program in 2013, we performed a comprehensive resource evaluation and did extensive business planning. We effectively skipped over classic molecular diagnostics in favor of taking our resources and investing in next-generation sequencing technology to be the backbone for the genomic medicine laboratory. We are heavily invested in Illumina NGS technology. We've been using, in general, the CGW by Purion DX for reporting and bioinformatic analysis. We do run our laboratory operation, and our EHR is all Epic-based, and we are heavily invested in molecular pathologists and have a medical geneticist on staff as well. So with that relatively brief introduction, we will turn our attention to locally insourcing genomic analysis and the topic of comprehensive genomic profiling, CGP for short. A solid CGP assay is, in my opinion, inclusive of both DNA and RNA analysis. There is mounting data that clinically relevant variants can be missed by DNA analysis alone. So I think CGP solutions, when touting quote-unquote comprehensiveness, should take this aspect of molecular biology into account. However, I would be remiss to not share with you my opinion that even if you have an assay that is designed to effectively interrogate the genome, the interpretation of the results for clinical care is a highly specialized practice that requires a mastery of medical communication, thereby underpinning effective translation of complex testing for clinical action. The key concept here is to make the investment in medical interpretation, which again, in my opinion, is a necessity for delivering on any investment otherwise in a genomic operation. So I'll turn our attention to assay design and development. Anyone with experience in this space will attest to the fact that NGS-based assay implementation in the clinical laboratory takes longer and requires more resources than is anticipated, even with the most insightful a priori plans. Due to the time from design to launch, and given the relatively rapid evolution of the biomarker space in oncology prior to CGP availability, there needed to be carefully informed planning at the early assay design phase to future-proof the assay in anticipation for biomarker needs at the point of launch and beyond. This is a challenging activity, and if inaccurate predictions were made, then oftentimes a laboratory could find themselves behind the times at the time of assay launch, thereby having to invest yet more resources and time into iterative assay upgrades. At this point, as depicted on the right, CGP options inherently future-proof assay development in this regard. And in the end, I would hypothesize currently that it may be a more economically sound option for oncology care delivery and clinical laboratories with the mission to provide clinically relevant biomarker testing. In regards to the role of the clinical laboratory as a key member in transdisciplinary care of cancer patients, I would like to impress upon you the difference between offering tests versus offering service. A service requires investment in medical leadership and staffing of the molecular diagnostics laboratory. There is currently a woeful underestimation and lack of recognition of the value this brings to the laboratory facet of transdisciplinary care. Building, maintaining, and scaling genomically informed cancer care requires a collective resolve, yet there must be a champion, and I am of the opinion that molecular pathologists can be very well poised to lead the effort, if in fact they are supported to do so. So what are the value-added services that benefit from and exist when they are supported by a so-called champion? To begin, the development of an informed professional service. At baseline, this is inclusive of clinically relevant assay design that is informed by molecular biology and balanced with clinical needs, all the while validated and run according to professional clinical laboratory standards. But beyond the development of a sound assay, a service includes supportive care pathway design that may be inclusive of reflex testing protocols, which can significantly mitigate non-informed cancer care and ensure equitable access to biomarker testing considered standard of care. Additionally, a well-qualified champion can establish standards and practices for tissue stewardship that can drastically reduce quantity not sufficient rates. And finally, local access to professional logistical support when it comes to accessing and utilizing genomic information is significantly challenged without investment in a champion who can lead the charge on genomic literacy, thereby establishing local rapport upon which we move the needle forward for genomic medicine and our patients. An example of care pathway development and no small feat is establishing reflex testing policies at the local level. We managed to do exactly that for advanced non-small cell lung cancer in early 2018. We hypothesized that the implementation of the reflex for patients with advanced non-small cell lung cancer would result in quality improvement. We therefore reviewed 578 small biopsy cases and assessed the impact across 3 workflows: the send-out testing period before we implemented in-house testing, but that testing was ordered by a clinician in the EHR, and then in-house testing utilizing a reflex protocol at the time the morphologic diagnosis was being rendered by an anatomic pathologist. And some of the outcomes that we looked at were rate of biomarker-informed testing and care, rate of test failure by workflow and methodology, initiation time, so how long did it take to initiate genomics after the diagnosis was made morphologically, and then reporting time. What we found is summarized in this table. Essentially, during the send-out period, testing was ordered in only 55% of patients that should have had the testing ordered. Of that 55% that actually did get a send-out, 16% of those cases were returned as quantity not sufficient. There was a relatively low rate of rebiopsy, and ultimately of that 55%, 14% of those patients had non-biomarker informed care despite the send-out. Overall, the total non-informed care during that period of time was approximately 60%. As we moved to the in-house testing, and there was awareness, now we had it implemented in-house, we were doing a lot of education. The testing was ordered 85% of the time in all of the cases that should have had it ordered. It was ordered more quickly after the anatomic diagnosis was rendered. The quantity not sufficient rate dropped significantly to 5%, and the majority of those cases, if not all, initially, even before extraction, were really borderline cases to begin with. The rebiopsy rate was relatively low, and ultimately in this group of 85% of orders, 4.5% of them did not ultimately get genomic analysis performed because of quantity not sufficient. In the end, the total non-informed care plummeted from 60% to 20% just by bringing the testing in-house. In the end, upon implementing the reflex, 100% of our patients that should get this testing are getting this testing ordered. It's ordered as a reflex by the anatomic pathologist the same day the anatomic pathology diagnosis of cancer is rendered. Our QNS rate is still bouncing around that 5% mark. The rebiopsy rates are still relatively low, so the non-biomarker informed care currently is bouncing around 5%. And because the testing is ordered 100% of the time in the patients that should be getting it, the total non-informed care with the reflex has now plummeted from 60% to approximately 5%. So in conclusion, I'd like to begin by saying stakeholder engagement and commitment from leadership is foundational for local implementation of genomics into healthcare. Importantly, clinically validated, high-quality assays do not equal a genomic medicine service. Genomically informed cancer care requires collective, transdisciplinary resolve, but the realization of that collective resolve and operationalizing a genomic medicine service requires a champion. I hope I've impressed upon you today that there currently is an under-recognized value of the molecular pathologist, and where much of the value lies is in the informed design of care pathways supportive beyond the assay, leading to advocacy and development of information systems supportive of genomics in practice, optimizing tissue management, improving time to testing, establishing workflows that can result in the plummeting of non-informed cancer care, improving genomic literacy, and lastly, but very importantly, ensuring equitable access to genomically informed cancer care. In the end, local practice matters, and I thank you very much for your attention today.
Hello, my name is Jeff Conroy. I'm Chief Scientific Officer at OmniSeq and also Director of Genomic Technologies at Roswell Park Comprehensive Cancer Center. And I welcome you today to our Illumina workshop at AMP 2020, where I'll discuss comprehensive genomic profiling and how we apply this to precision medicine in solid tumors. Today I'll be discussing my relationship with OmniSeq and the work that I performed there. Before I begin, I thought it'd be good to give an overview of OmniSeq. We are a molecular diagnostic reference laboratory in upstate New York, specifically in Buffalo, located on the Buffalo-Niagara Medical Campus. We are a CAP-accredited, CLIA-certified New York State Department of Health laboratory, also with ISO certification. And our goal is to get patients onto the right drug or to the right trial by doing molecular diagnostic testing. We have experience with over 50 laboratory-developed tests, including 6 next-generation sequencing assays for comprehensive profiling. Today, I'd like to give an overview of how we use biomarkers to support precision medicine opportunities in solid tumors. And we'll start with traditional approaches, and then how we moved at OmniSeq to comprehensive genomic profiling, as a means to do multi-marker, high-throughput patient testing, and then talk through some of the technology advances that allow a comprehensive genomic profiling approach to be done in a quick turnaround time with the analysis, reporting, and interpretation tools that support this type of test. Over the past several years, we've seen a revolution in oncology therapies, starting with chemotherapy, where patients had a dramatic response for some cancers, but poor response for others, and not really a means to identify which patients would respond to chemotherapy. But once biomarkers were discovered and targeted therapies were shown to improve outcomes, there was a wave of new discovery that led to multiple approaches for molecular targeted discovery and also for immuno-oncology. And these were all driven really by biomarkers. And biomarkers come in several different classes, and they're all needed to be evaluated to progress patients with personalized medicine approaches. To do tumor profiling, it's important that biomarker classes such as copy number aberrations of gain and loss, somatic variants such as SNVs and indels, fusion and splice variants, PD-L1 as a marker for immune oncology opportunities, and both TMB and MSI as biomarker signatures are all evaluated so patients can get stratified onto the right treatment options. This is true not only for clinical testing, but also for drug development as pharma is trying to grow their drug development efforts. Most of the biomarkers that have been identified to aid with personalized medicine approaches have a strong functional understanding. Many biomarkers are involved in pathways that, if dysregulated due to different variations in that gene, can cause differentiation, growth, and metastasis. The biomarker classes that are identified by comprehensive profiling and traditional profiling are highlighted here. FGFR, EGFR, HER2 are all known oncogenes that play a big role in driving tumor growth. And to be able to detect the different variations in these biomarkers is very important. Along with reviewing the tumor microenvironment, tumor mutation burden, PD-L1 are important molecules and markers that are needed to look at the totality of the tumor inflammation, and also to understand if there are other mechanisms within the tumor that should be addressed for personalized approaches. And then, of course, DNA repair with microsatellite instability and the BRCA genes are all needed to look at the total tumor profile for appropriate testing. So traditionally, these various biomarkers are done as single analyte tests that are very tumor-specific and marker-specific. It involves multiple technologies, including immunohistochemistry, FISH, and PCR-based approaches. And these traditional analyses are often restricted in their content and really require an iterative approach to doing the testing, where the first couple slides might be used to look at gene A, and then another set of slides for gene B and gene C, et cetera, as results are produced. And, you know, it really does impact sometimes the turnaround time and the specimens that are needed to do a full testing portfolio. As an example, with non-small cell lung cancer, NCCN guidelines recommend a multitude of biomarkers be tested, and in some situations, this could require at least 30 slides. In addition, it can be difficult for laboratories to keep up with the ever-growing list of FDA-cleared or approved companion diagnostic devices for solid tumors. Not only does it require training and competency of the technicians in all these different devices, but also the maintenance and support of all these equipment in the laboratory. So how does comprehensive genomic profiling alleviate some of these challenges with this single analyte traditional biomarker approach? At OmniSeq, we've adopted comprehensive genomic profiling as our test of choice. so we could look at multiple biomarkers on a minimum specimen to give a single consolidated report. Specifically, our assay is looking at over 500 genes and looking at the biomarker classes discussed earlier, with SNVs, indels, copy number variants. The assay can detect novel and known fusions and splice variants. Also can look at the biomarkers for TMB and MSI for immune oncology. And we also incorporate PD-L1 and gene expression profiling in our comprehensive test. All of this can be done with DNA and RNA from a single isolate of tumor. What is great about having a comprehensive assay such as the OmniSeq 500 test is that it has enough markers on the panel where you can do the TMB and the MSI detections. In addition, it is future-proofed in that it contains new and emerging markers that follow the FDA CDX pyramid, whereas more evidence is gained, markers can become companion diagnostics and have guidelines around therapy. Specific to our OmniSeq 500 test, as few as 10 to 12 unstained slides are required to do all 500 biomarkers and all biomarker classes. This translates into as little as 40 nanogram of DNA and 20 nanogram of RNA as inputs that are co-extracted during our nucleic acid extraction process. And the test can handle and is validated for pan-cancer solid tumors, including needle core biopsies, resection specimens, and cell blocks. There are always questions around how well comprehensive genomic profiling can perform, and especially when it comes to specimens like lung cancer specimens, needle core biopsies, and small sections that typically come into a molecular diagnostic lab. And we've shown that the specimen failure rates, given the minimum inputs of 40 nanogram of DNA and 20 nanogram of RNA, actually are very low. And in fact, with the first pass, we have a 96% success rate with the DNA samples, and on retesting, it jumps up to 98% overall. And with RNA, similarly, we have a 93% success rate on the first time of testing, and on a retest, we jump to 98%. And I believe this is very in line with what single analyte testing should expect for failure rates. So even though we can use as little as 40 nanogram of DNA and 20 nanogram of RNA and 10 to 12 unstained slides, we're able to have very robust assay performance in analytic sensitivity and specificity as shown in this slide. Here are a number of level 1 biomarkers along the left-hand column, and their percent agreement of the OmniSeq 500 assay versus validated next-gen sequencing comparator methods, whole exome sequencing, real-time PCR, single analyte tests, or FISH assays. And as you can see, we have very high agreement between the OmniSeq 500 assay and the externally validated comparators for all of these level 1 mutations. To drill down just a little more into the biomarker class of copy number gain, we show here the concordance and the correlation of fold change between the OmniSeq 500 assay and the externally validated next-gen sequencing assay, showing very high correlation, and this is on 17 copy number gain genes and over 120 samples. Looking at TMB, we see similar concordance between the OmniSeq 500 assay and an externally validated next-gen sequencing assay. We are part of the Forensic Cancer Research study, which has a goal of harmonizing TMB across several platforms, and we are using data from that effort and internally to demonstrate that comprehensive genomic profiling panels that are at least a megabase in size, do have equivalence to whole exome sequencing and can be used across laboratories with confidence for calling TMB. So now that I've demonstrated, the robustness of comprehensive genomic profiling across a few variant classes, I'd like to discuss in a little more detail on the technology innovations that allow for quick analysis, reporting, and interpretation of all these biomarkers. Fortunately, there have been enough advances in information technology solutions that allow laboratories such as OmniSeq to perform high-throughput tumor profiling and achieve a 7-day turnaround time from sample intake to reporting. And it involves a collection of systems that need to be integrated together, but the solutions are there and available for laboratories to perform comprehensive genomic profiling. In our case, we have 4 different solutions, one starting on the left side called Connect that handles all the order entry, specimen collection, payment verification, and order intake functions of the laboratory that then message those order entry informations to a LIMS system where we do all the laboratory work such as slide preparation and library preparation and sequencing. And then we move the data from the sequencers into either a cloud or a local environment for high-performance pipeline analysis. We are running currently 144 samples per batch, 72 DNA and 72 RNA paired samples in a run. And all that data then moves from the pipeline into our laboratory information system for marker annotation, filtering on quality metrics, and clinical association of trials and therapeutics. In that state, the sample reports are reviewed and signed out by the pathologist. So in total, the OmniSeq 500 comprehensive assay allows for the reporting of greater than 500 markers for targeted therapies, 395 markers for immune-related therapies, and also the PD-L1, TMB, and MSI biomarkers for immune therapies. Overall, it represents 18 different targeted therapy level 1 markers, 71 FDA level 2 markers, and 126 FDA level 3 markers, all shown in red to the left. And in addition, the gene expression profiling component serves up 34 druggable immunotherapy biomarkers that are available as clinical trials. So to conclude, we discussed how biomarker detection is important in progressing personalized medicine, whether it's with targeted therapies or immunotherapies, and that comprehensive genomic profiling, not only does it maximize tissue utilization from these often scant tumor biopsies, but it can produce biomarker information across all the biomarker classes and mutations that are required to get a full picture of the tumor. And I think that it's safe to say that, having a complete picture of the tumor is certainly what makes decision treatment options easier for clinicians, and that they can look at data and adjust their treatments over time as patients become resistant to certain therapies and need to move on to combination therapies. And without the advances in IT solutions, LIMS systems, and laboratory information systems that are built to support high-throughput comprehensive profiling, it would be very difficult to have a 7-day turnaround time. So I thank you for your time, and feel free to reach out to us at OmniSeq for further questions.
Hello, my name is Jeremy Wallentine. I am the Laboratory Director at Intermountain Precision Genomics, which is part of Intermountain Healthcare, a large integrated not-for-profit hospital system that serves the healthcare needs of people across the Intermountain West, primarily in Utah, but also extending into southern Idaho and southern Nevada. But quickly, I would like to disclose that the opinions expressed during this presentation are those of the speaker and may not represent the opinions of Illumina. Any uses of Illumina products described in this presentation may be uses that have not been cleared or approved by the FDA or any other applicable regulatory body. So Intermountain Precision Genomics' mission is to provide important genomic information that allows for a truly personalized approach to the patient's care, including precision cancer care, pharmacogenomics, inherited or germline genetic testing, and genetic counseling. Key to the precision cancer care effort is our comprehensive genomic profile assay that we call TheraMap. TheraMap is a mature, one-step solution for comprehensive tumor profiling. The assay includes 523 genes for DNA sequencing and 55 genes for RNA sequencing, making up a total panel size of 1.95 megabases. It combines a complete immunotherapy picture with tumor mutational burden and microsatellite instability status that is further enhanced when combined with PD-L1 expression status by immunohistochemistry, as is done in the majority of cases. Shown above are data taken from our validation study showing positive percent agreement and positive predictive value for the given variant type. Overall, our validation analyzed 130 clinical samples across a wide variety of solid tumor types that had previously been characterized by other next-generation sequencing assays, as well as a small subset of cases and samples with PCR and FISH results. Not shown above, but worth mentioning, is our tumor mutational burden validation, which included 24 samples, 15 clinical and 9 cell lines, comparing whole exome sequencing data to TheraMap for tumor mutation burden calculation. The correlation with this initial data set had an R-squared value of 0.9204. However, additional data from 29 clinical samples performed as part of our group's participation in a national TMB focus group increased the R-squared value to 0.9757. So the validation data demonstrate a highly sensitive and highly specific assay across a wide variety of variant types with excellent correlation for TMB calculations as compared to whole exome sequencing. Quality has been key to the success of both the assay and clinician engagement. The quality of our implementation stems from three things. First, a high-quality assay out of the box coupled with a solid bioinformatics pipeline, a focus on quality implementation in our laboratory that includes running synthetic positive samples from SeraCare for both DNA and RNA on every run, and third, a focus on careful and well-curated variant interpretation using our own team combined with the strength of PureDX for variant and data management and report generation. The bioinformatics pipeline that we employ is a hybrid model that utilizes a combination of third-party vended solutions, internal host servers, and a custom-developed QC pipeline that analyzes both samples and controls. Variant call files, BAM files, and other metadata are then uploaded to PureDX platform where our clinical variant scientists run additional variant filters and curate remaining variants for clinical reporting. Shown above is a sample TheraMap report. The report organization brings the summary of findings to the top of the report and includes both pathogenic and likely pathogenic variants, a TMB score, MSI status, and when ordered, PD-L1 expression status. Upon lab director review and approval, the report goes to a molecular tumor board, which is a unique feature of our product. The molecular tumor board is staffed by a group of oncologists with expertise in molecular genetics and molecular oncology. The molecular oncologists review the findings and in the context of the tumor type provide a ranked list of recommendations. Shown above or here is the molecular tumor board cover sheet, which allows us to make clear and concise therapy recommendations to the ordering physician and essentially boil down what can be a very complex and sometimes overwhelming report into a single page with actionable recommendations. The molecular tumor board interpretation and TheraMap report are then delivered simultaneously to the ordering clinician in our electronic medical record. The combination of these reports has given our oncology team peace of mind, providing a nearly complete view of therapeutic options available to the patient, including off-label mutation-specific therapies. As previously mentioned, quality is key to the success of the assay, which in turn, over time, builds confidence in the results the assay returns to the clinician. Key to this effort is running SeraCare, DNA, and RNA standards in every run. Shown here are SeraCare run results from 120 production runs performed by 7 technologists using 5 sequencers over 19 manufacturer lots. As you can see, the positive % agreement is excellent with relatively few false negative results. High quality and reliability are key to building trust around the assay, but regardless, clinicians will always ask for faster turnaround times. Through improvements made throughout the testing process, we have been able to bring our average turnaround time down to about 10.6 days, which includes the molecular tumor board interpretation component. And for context, the lab is only operational 5 days per week. Also shown on the right of this slide are the most common mutated genes in all tumor types that we have discovered, as well as the most common mutated genes in lung cancers. The proportions of mutations shown here reflect what we expect to see in these tumor types. Prior to TheraMap, the majority of our in-house testing for lung cancer, for example, employed the use of multiple single gene assays that made up our in-house lung biomarker panel, and these included EGFR and BRAF by RT-PCR, and ALK, ROS1, and PD-L1 by immunohistochemistry. In 2018, we performed around 200 lung biomarker panels. This has now dropped off to essentially 0 in 2020, and as of today, we've officially retired our EGFR real-time PCR assay. The change from single gene or single biomarker testing to a comprehensive panel-based approach has been driven by a combination of factors that include inherent efficiency of a single comprehensive panel, which is key in lung cancers and other samples that have limited tissue, increasing utility of immunotherapy, and attempts to adhere more closely to guidelines from bodies such as the NCCN and AMP, CAP, and IASLC. As noted on the slide, we submitted and received positive coverage from MolDX in early 2020. Also shown on the right are therapy recommendations made by our molecular tumor board and a list of the tumor types that we have tested thus far. No surprise that the most commonly tested samples are colorectal carcinomas and non-small cell lung cancers. In summary, we have validated and successfully implemented a comprehensive genomic panel that covers a wide spectrum of variant types and immuno-oncology biomarkers with industry-leading turnaround times that have not required any compromise to overall quality.
Welcome back, everyone. I'd like to thank our panelists for these wonderful presentations. Now we'll move on to some open dialogue with Q&A. We'll be covering various topics related to comprehensive genomic profiling. So, Jeff, as comprehensive genomic profiling is increasingly becoming the standard of care and testing volumes are expected to grow, how are you preparing your reference laboratory to accommodate the anticipated growth?
Yeah, that's a very good question. Performing the comprehensive genomic profiling testing is almost a routine part of the whole exercise now. The technologies have advanced so much. The library prep kits and the sequencing and the pipelines are there. It's really now about creating the infrastructure required to support the whole operation, all the activities of a high throughput lab such as ours. That's the larger challenge right now. And so we're investing a lot in automation around extractions and library preparation. We're building out IT systems that can handle the front end of everything that we do, from order entry, tissue QC, all the way through to the report signouts. And I think really as comprehensive genomic profiling grows, it's more the infrastructure to support all of that for quick turnaround times that's becoming the challenge and what we need to do to grow with the demand.
That's great. Moving on to Nikki. So tumor mutation burden, TMB, has recently been in the news with the approval of pembrolizumab for late-stage cancer. Additionally, the inclusion of TMB in the NCCN guidelines for cervical cancer and both thyroid carcinoma. In your opinion, how much of this influences the adoption of a comprehensive genomic profiling assay, which can accurately call TMB in combination with other key biomarkers for immunotherapies and targeted therapies. As a follow-up, are you seeing this growing demand for TMB testing from your oncologists?
Thanks for the question. Yeah, there's certainly, we didn't get into the space with CGP until we felt that TMB was gaining traction. And certainly, you mentioned it is making its way now into a more standard of care, certainly more tumor types. And currently, with the tide turning in that way, there's been chatter for several years now on TMB. It's getting increasingly louder. And so certainly with some of the more recent approvals, it definitely made an impact in terms of our decision-making to implement an assay of that size for our cancer care here.
Jeremy, do you have any thoughts around the same question, immunotherapy and TMB?
Yeah, so our experience may have been just a little different because we went live with our assay and were pursuing our assay prior to TMB becoming more widely accepted. And so we struggled with getting clinicians to buy into a large panel with TMB where they may have initially been preferring smaller focused panels that didn't have TMB. Whereas now that we're seeing, such a shift with FDA approvals and other guidelines, that there is more widespread buy-in to use an assay that includes TMB. And so that has shifted. And we have also seen our coverage, our payers be more willing to cover the assay.
And Jeffrey, within your organization, it would be great to hear your perspective on this as well, especially given the scalability that you're looking at in order to accommodate the growth.
Yeah, TMB is certainly a biomarker of interest. I think oncologists are always looking for biomarkers to support their clinical decision-making, whether it be, on-label targeted agents, checkpoint inhibitors, trials. And, really, there are a large number of patients that are, mutation negative and PD-L1 negative. And so that TMB positive result does give them, an opportunity, to get a patient onto an approved, therapy. And, what we're finding is that it's important to have a large panel to be able to include that result at the same time as your other individual markers. And so as a result, I think CGP is certainly poised as large panels of at least a megabase, upwards of 2 megabase to be, the preferred platform going forward. And, we're part of the Forensic Cancer Research project where we're attempting to harmonize TMB reporting across several different platforms. And that can only help, with laboratories to be able to calibrate their tests, harmonize, and to be able to report out, especially that cut point of 10 that's been thrown around for multiple cancer types for Pembro.
Absolutely. And so, Nikki, let's come back to you. Many therapies targeting gene fusions have been recently approved. Can you sort of describe your view on the different approaches for fusion detection? For example, DNA versus RNA-based detection, and how does hybrid capture compare to Amplicon, NGS, or FISH?
Yeah, sure. Certainly I may be biased by how our practice got started here back in 2013. We had a decision to make when we were starting this operation with the resources we had. Were we going to develop from ground zero a molecular diagnostics menu like other labs in sort of our academic space, or kind of forego a lot of that, jump over it, if you will, and invest in next-gen sequencing as a backbone technology for a genomic medicine laboratory? And we did the latter. And initially, we got started at that time with DNA-based sequencing. We've always been a hybrid capture lab. It's worked really well for us. There was a lot of chatter about using DNA to call fusions, and we found it didn't really work too well. And some people who were calling it out as, yes, it's working for us, seemed like maybe they weren't using it either. So when RNA technologies came along, I think we were a relative early adopter of doing RNA in parallel with DNA. I think it optimizes sample usage. The predominant sample type that comes to our lab is non-small cell lung carcinoma. I think it's notoriously the most challenging sample type to work with. And we've had phenomenal results in terms of getting as much information from a small sample and having very low QNS rates. So I also like RNA sequencing for kind of cutting to the chase, if you will, right? And you get to see the direct fusion product. And that's, I think, nice from our practice perspective. So, I'm a fan of kind of doing it all in parallel. I think also, there is some data out there to show, from big sequencing operations that, if you do just the DNA, you end up missing things that are actually clinically actionable and have clinical benefit via the RNA, and then tying those to therapies. So, I'm a fan of doing both in parallel, and that's how we're going moving forward.
Yeah, it certainly gets to an answer quicker, right?
Yeah.
So I can certainly see benefits there as well, too.
Yes.
Jeremy, what are your thoughts around the same question?
Yeah, I would echo what has been said. I think we're also biased towards the hybrid capture, especially looking at lung cancer. We've had several examples of novel fusions that we likely would not have been able to or would have missed had we used, a very biased RNA-only approach. So I think we do appreciate the benefits of a hybrid capture model and being able to identify novel fusion partners.
And Jeff, do you have any further thoughts around the same topic?
Yeah, we made a similar transition where we were first doing everything with fish break apart probes where they were available, and then had the decision, how do we incorporate fusions and even splice variants into our next gen sequencing and comprehensive profiling, and made the decision to go to RNA for many of the reasons that the panelists have said. We do believe that the high capture method, in addition, because of its ability to be able to pick up novel, fusions, is a real benefit. We may lose a little sensitivity with high capture versus amplicon based, but I think in the end here, both avenues with RNA sequencing certainly have a lot of benefit to picking up with high precision, these very rare variants.
Great. Let's move on to another question now. Nikki, you presented some very interesting data on how internalizing comprehensive genomic profiling at the University of Vermont has helped you significantly increase the number of informative cases, as well as reduce the QNS rate. Can you sort of elaborate on your reasons why you believe this happens? And can you also comment on how this, directly impacted patient care?
Yeah, sure. So to be honest, I think the answer to your question is multifactorial. First and foremost, stakeholder engagement and commitment from leadership for us was foundational for local implementation of genomics into healthcare. And with this came investment in medical leadership in the laboratory to spearhead and champion care pathway development that is supportive beyond just the assay. I shared with you in the presentation that I'm of the opinion that molecular pathologists can be very well poised to lead the effort. But it's important to understand, and I think, obviously the panelists do, that the practice of pathology is classically broken down into anatomic pathology and clinical pathology. What's interesting about molecular pathology is how intertwined it is with both divisions. In the end, what that means is that molecular pathology, again, in my opinion, is as a practice is best delivered when the service being offered is informed by leadership that understands the life cycle of samples from both sides of the house. The concept of more information from less or the same amount of sample is very well understood and generally a universal challenge no matter what your practice type. And so therefore, I think a molecular pathologist with broad training in the trenches, if you will, is well poised to take on tissue stewardship and lead care pathway development to that end. But I think finally, I also want to call out the tissue journey. Key steps of that journey include the tissue acquisition, tissue management, and engagement of multidisciplinary personnel. And the tissue journey, again, this is in my opinion, I think it invariably differs across local practices. And of central importance for successful insourcing of genomic analysis is being able to align NGS assay requirements with clinical and anatomic pathology practice considerations. And so this requires an investment in a champion of these efforts. And it's the role of that champion to identify, engage, and educate all key personnel about assay requirements and the value of precision medicine. And so insourcing genomic analysis, I think, is also best served when the champion of the effort also proactively engages with payers, right, to educate them not only about the assay, but around assay delivery and what's being done locally and how that benefits, their group. But the last point that I need to make is that the champion must engage with information services personnel. And again, that's to educate on the importance of investing in systems, information systems that facilitate transdisciplinary communication throughout that tissue journey, because so many different facets of the healthcare system touch the tissue and the patient throughout that journey. And so to summarize, I think, when there's an investment in molecular pathology as a service that includes support of a champion of biomarker-informed care, you have a really good opportunity to systematically develop a service as opposed to simply develop and offer tests. And it's the service, inclusive of all of the education and logistical support, that results in quality improvement that we've experienced here locally, in Vermont and Northern New York.
Very nicely summarized. It really highlights how we're moving a step closer to personalized medicine and taking into account all of the information that's received for testing. Jeffrey, we're noticing a fast-growing number of biomarkers linked to immunotherapy or targeted therapies being approved. We talked a little bit about the challenge of small biopsies, particularly in non-small cell lung cancer, et cetera. Can you describe your views on the future of iterative single gene testing with modalities such as PCR, IHC, FISH, and how implementing CGP is going to impact your testing tree decision? And I would also open up this question to the rest of the group as well, too, because I think it's certainly relevant to all institutions.
Yeah, certainly. That was the issues and the problems we had early on when we were running single amyloid tests across lung cancer, especially for multiple markers with very small biopsies, needle core biopsies. Maybe we could get, 10 to 15 unstained slides, and we were quickly depleting the blocks and only had a few biomarkers, tested. So, and I think NCCN guidelines now for numerous tumor types, agree that, broad molecular profiling is something that's recommended, and next-gen sequencing and comprehensive genomic profiling fit that bill quite well. If you look at all the indications right now or all the different biomarkers and therapies for lung, you could require up to 30 unstained slides to test each one of those iteratively, where maybe half that is required to do it comprehensively and have all that data come out on one report with, clinical evidence served up for either actionable, therapeutic options or clinical trials or immunotherapies is, I think, a real benefit to the physicians and the patients that we serve.
And Jeremy, it would be great to hear your perspective in how this, impacts testing at Intermountain Healthcare.
Yeah, certainly we were there, 4 or 5 years ago with the iterative testing, and we're running into problems, running out of tissue, dealing with small needle core biopsies, in particular with lung cancer. And so certainly there's definitely been a shift and buy-in with the clinicians wanting to do one test and do the right test and do it just once. But I think also you have to, as was said previously, look at the tissue before it gets to the lab for sequencing and how the pathologist is handling it. And so that's been a very important piece of Intermountain Healthcare, is to make sure that the pathologist and the pathology lab know that the biopsy, that the tissue needs molecular testing, or that the clinician is maybe doing the biopsy for the purposes of molecular testing alone. So we've created a checkbox on our anatomic pathology requisition form called molecular priority, to try to indicate to the histology, to the gross room, the histology lab, and the pathologist that molecular testing is a priority with the sample, so that we minimize immunohistochemical workups or stains, or don't repeat those immunohistochemical stains and workup, and have enough tissue for a comprehensive genomic profile assay to be performed.
And Nikki, would you like to share sort of your experience in the testing tree, decision tree?
Yeah. I mean, I guess we're kind of fortunate in that we didn't have to wean anybody off the iterative pathway, and we just got to jump straight to the genomics, which was great. I definitely want to echo what was said, as an earlier answer to this, and the fact that the NCCN guidelines, acknowledge that broad molecular profiling is recommended for optimal sample usage. That is absolutely our experience, and that of my colleagues in the space, and has been echoed by the panelists as well. That to see that in black and white, I remember the first time I read those words in the guidelines, and I thought, finally, this will decrease the angle of the mountain we've been running up for a decade now. So I hope we continue to get the recognition and support for this technology.
That's great. And I would say, ask, in your experience, and this is open to all of our panelists here, can you recall a case where biomarker was detected by comprehensive genomic profiling, whereas it was previously negative using some of these more traditional technologies or other approaches? Anything interesting that really did alter the management of the patient care?
I'll jump in here, and we've had a few, I think, cases, especially with fusions, FGFR2 fusions, especially with urothelial. We've had a couple that haven't had partners to the traditional partners that are seen in the CDX assays, and our understanding is that those patients respond. And we've also had instances of, very low allele frequency resistance mutations like T790M in lung, especially, that could not be detected by some of the conventional methods. And we needed very, high sensitivity assays like you can get with next-gen sequencing to get down to that 1% to 2% varying allele frequency of detection.
Thank you for sharing those examples. And, as you think about targeted, biomarker testing and clinical trials, Jeremy, how important is it to provide access to clinical trials at your institution? Are you noticing a direct impact in the number of patients who are eligible for clinical trials due to the comprehensive testing?
Most certainly. We have a molecular tumor board that meets every other week, and it's pretty much seems like every patient, if not every tumor board, we're recommending a clinical trial or enrolling the patient in a clinical trial. We also have more clinicians that are joining the oncology program that are interested in setting up and being involved with clinical trials. So it has become a central focus in the oncology clinical program at Intermountain Healthcare to participate and enroll patients in clinical trials. And it's certainly made their life a lot easier having access to a CGP assay with such broad coverage.
And Nikki, can you share your experience with sort of accessing more clinical trials with comprehensive testing?
Yeah, I mean, I think our experience might be a little different. We are a much smaller cancer center. And so I think it's our experience. And so I think, yes, there are more patients that are getting access to clinical trials. I think, but more importantly, even in a small place like this, it's making sure that and ensuring, right, moving to 100% of the time, this particular tumor type should have this fundamental information available and for treatment decisions, and that information is there, right? So just being able to make sure that occurs as a standard of care and shoring that up has been really important here. Whether the patient's getting treated at the institution or even in some of the outside private setting. Practices.
Absolutely. And Jeffrey, can you comment on the same question around the importance of clinical trial access at your institution, either internally or externally, probably more so externally, and if you've seen an increase with that?
Yeah, certainly having additional biomarkers reported at the time of that initial testing, I think helps in the longitudinal care of the patients. Unfortunately, most patients, don't benefit from a single agent targeted therapy either. They get resistance and need to go on to another treatment course. So after you maybe exhaust the targeted therapy or the immunotherapy based on some of the biomarkers that you get, it's the clinical trial and the combination therapies that are likely the next level that physicians are looking to help get their patients onto. So, we believe that having all of that information available right away at the time of the report opens up all those avenues of targeted therapies, immunotherapies, and clinical trials.
Great. Jeremy, let's switch over a little bit to reporting. Can you comment on how your sequencing data is managed at your institution, from the raw data to the final reporting, including discussion on curation and interpretation, and how are the oncologists responding to the reports and the amount of information they receive from large panel testing?
Yeah, so we're using a bit of a hybrid approach that includes secondary analysis of FASTQ files. So we are using the TSO 500 pipeline Docker through Illumina, but we host that on a local server. And we've also developed a number of custom QC pipelines that analyze both the samples and the controls after the TSO 500 pipeline Docker. For the batch controls, we also do our own sensitivity specificity analysis and look at depth of coverage uniformity at 25, 50, and 95%, which may be a little unique. And we're also generating coverage distribution plots and low coverage gene analysis. And after those pipelines are finished, the QC is reviewed by bioinformaticists prior to uploading it into Purion DX, which is what we are using. The clinical variant scientist will review the variants in Purion DX and use a set of filters based on the validation that will remove variants with low quality or low VAF, And once that's complete, they'll curate the remaining variants and generate a report. But of course, these reports can be lengthy, they can be complicated and overwhelming. It's been important to design a report that the clinicians can wrap their heads around. And so we've moved all the important information to the top. We try to highlight it. And we also include a molecular tumor board cover sheet. So all of our tests will go to a molecular tumor board where 2 or more molecular oncologists will review the results and provide a rank list of therapy recommendations. And that is also helpful, allowing clinicians that may not be as familiar with molecular oncology to sort of decide, okay, what is most important? What should we focus on with this patient and this tumor? So the combination of the report structure and then the molecular tumor board piece, I think, has enabled clinicians that may have had less experience in molecular testing to feel more confident in this space.
Thank you for the overview. It's very helpful. And this is another interesting question. I think it'd be great to hear your perspectives around liquid-based biopsy testing. So, there's a lot of excitement around liquid biopsy, and with the emergence of a comprehensive genomic profile based off of liquid, can you sort of describe, Jeffrey, your view on utilizing such a panel? Would you consider it complementary or as a potential replacement to tissue biopsy in some instances?
Yeah, there is a lot of excitement, and we share that excitement with the potential of liquid biopsy. And I think it all starts first with what's the intention of that test and how we're going to serve our patients. There's certainly early detection, intended use cases. There's the identification of markers for targeted therapies, and also there's the use case of monitoring, disease and response, longitudinally. So I think, we're focusing in the middle there of trying to have a complementary assay on detecting mutations that can be an option here for patients that can't do a tumor biopsy. And for those that maybe have failed tissue QC or sequencing off of that tumor biopsy for whatever the reasons. So certainly we're looking at it as right now as a complementary, assay, and certainly are very excited about the potential, of liquid biopsy in the future for more than just that.
Thank you. And Nikki, it would be great to hear your opinion on the same topic, where you think it fits into diagnostics.
Yeah, sure. I think that there are certain cases that no matter how hard you try, you cannot get the information from tissue. We've been really fortunate here with extremely low quantity not sufficient rates due to the fact that we optimized our testing for all cyto preparations, non-cell block cytology preparations, cell block, and then everything surgical pathology. Doing something like that and having cytology expertise during the point of triage of tissue and optimizing what you are able to enter into your NGS assay, you truly can get very low quantity not sufficient rates. So, that being said, there's always going to be a subset. And so to have that liquid biopsy option in that subset of patients is a good backup plan. I know that there are some proponents out there of let's order both things simultaneously in case the tissue fails, then we'll get to have the liquid biopsy answer because that might not fail. I think there's only so many healthcare dollars out there. I personally don't agree with that practice. I think it's irresponsible. I could go further. I'm a passionate Greek person. So I will just say that I think we also need to be, mindful of what we're doing with our limited resources. We can do better with tissue in general. But in the meantime, I think it's an exciting field to follow. We certainly are following it with excitement. And, when we feel it's ready and we feel we're ready to take that on, certainly I think a lot of us are excited to do so.
Thank you for your response. And Jeremy, what are your thoughts on the same topic?
Yeah, I share a lot of those views in that it has its place. We haven't seen a lot of concurrent ordering of liquid and tissue at the same time. We've seen it more commonly utilized when there's insufficient tissue for the testing and a repeat biopsy is not a real good option, either for patient safety issues, for example. And so the liquid biopsy offers a really nice backup plan. But I do see them more complementary than liquid biopsies becoming a replacement, though I do see liquid biopsies in the future being used more commonly for MRD testing.
That's a great point, especially once at diagnosis, if you can establish the biomarkers in both the tissue and the blood, you could potentially follow the patient, with blood. It's been shown to be more sensitive than, imaging modalities and other modalities. So very great point. Well, this was an exciting discussion. This concludes our QA session. I'd like to thank our panelists for, spending time with us and for their thoughtful participation around this very important topic. You all come from various institutional backgrounds, and so it's helpful to have your collective insight. Thank you very much.